We're going to see pulmonary hypertension. Pulmonary hypertension could be many causes, primary or secondary. Obviously, primary is idiopathic, secondary is secondary to many causes. We're going to divide it in 5 major categories. First is idiopathic, then due to left-sided heart failure. Third is fibrosis and chronic hypoxic vasoconstriction. Hypoconstriction of the lung. This is when there is generalized hypoxia. We have vasoconstriction in the lungs. In each organ, when we have hypoxia, hypoxia for that organ, it vasodilates its arteries. In the lung, when we have a region that is without well perfusion, we vasoconstrict that area of the lung. Like in a pneumonia, we constrict that part of the arteries that are to the pneumonia part in which we are not oxygenating the blood. But if we have a problem generalized to all the lung and we have hypoxia in the lung, all the arteries of the lung are going to be constricted, and so we have pulmonary hypertension and hypoxia and hypoxemia. Next is the pulmonary thromboembolism. Recurrent pulmonary thromboembolism can lead to pulmonary hypertension. And 5 is multiple etiologies, including sarcoidosis, for example. So in idiopathic, this we don't know the cause. We have maybe it could be mutations in the BMR2 gene. This is more common in women. They present like chest pain, exceptional dyspnea, could be syncope. This gene codifies for things that inhibit the proliferation of the smooth muscle around the arteries. Both we have mutation, then we have excessive proliferation of the media of smooth muscle of the media of the smooth muscle that is around the artery, and we have hyperplasia of the media of the blood vessel wall, and fibrosis and hyperplasia of the intima, the first layer of the vessel wall. In left-sided heart failure, we have the right and left heart. We have or valvular disease could be from could be any damage to the aortic valve, could be regurgitation or stenosis, because on the way is going to cause hypertrophy of the left ventricle, and we can back up the pressure. Or could be even though just stenosis or insufficiency of the mitral valve, whatever that increases the pressure behind the left atrium is going to get in the pulmonary vessels and is increasing hydrostatic pressure, pulmonary edema, because it increases the hydrostatic pressure, so it promotes filtration. In fibrosis, here we have increased production of tumor growth factor beta. In the hypoxic vasoconstriction, this could be by many causes, including high altitude. In high altitude, we can have pulmonary hypertension. In fibrosis, could be idiopathic interstitial lung disease, or wherever it is cognitive interstitial pneumonia, many diseases of the restrictive lung disease. Thromboembolism, this is just pulmonary embolism. The treatment for this would be surgical removal of the thromboembolism. If we cannot do this, the alternatives are anticoagulation or some anti-aggregates. Anticoagulation, we usually give heparin and in the hospital, and warfarin for outpatient care, with heparin in the time in which warfarin takes the anticoagulant effect. And in this miscellaneous sarcoidosis, we know it could be many other diseases, Also, the diseases that causes respiratory acidosis, like COPD could produce this, or chronic obstructive sleep apnea. It produces apnea, it produces respiratory acidosis, and all this can go to pulmonary hypertension. The next best step is echocardiography, but the most accurate test is inserting a catheter into the right vein. We go all the way down to the right atrium, right ventricle, and pass through the pulmonary artery, and then we measure the pressure. If the pressure is greater than 25 millimeters of mercury at rest, it is diagnostic of pulmonary hypertension. If it is greater than 35 in exercise, it is diagnostic. Treatment for idiopathic type could be inhibitors of the prostanoids. Prostanoid is, for example, endothelin. So we are going to give an antagonist of endothelin because endothelin causes vasoconstriction. We also in this disease have decreased nitric oxygen and diminish prostaglandins.